My name is Dr. Timothy Smith, and I'm a neurosurgeon scientist and the surgical director of the Multidisciplinary Pituitary Center at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Today, I am joined by Dr. Larry Katznelson. He's a professor of neurosurgery and endocrinology at Stanford University School of Medicine and the medical director of the Pituitary Center there. In addition, I'm joined by Ms. Sharmyn McGraw. She's from Orange County, California, and she's been in remission for 23 years with Cushing's disease and has been a long-standing advocate both nationally and internationally for pituitary patients. And in this section today, we'll be discussing the challenges in the medical management of patients with Cushing's disease. Larry, could you help explain to us what is Cushing's syndrome and Cushing's disease?
Sure. Thank you so much, Tim. I think it's important first to set the definitions of Cushing syndrome and Cushing disease. So Cushing syndrome refers to a disorder associated with high levels of steroids or glucocorticoids. The most common cause internationally is iatrogenic, meaning patients who are taking too much steroids for other medical disorders. If one looks at the endogenous causes of Cushing syndrome, where there is disorder emanating from a tumor or other disease within the body, the most common cause is Cushing disease, which refers to a pituitary tumor that's producing ACTH. Now, just for the sake of definitions, we divide the types of Cushing syndrome into those which are ACTH dependent, meaning that somewhere in the body, most commonly a pituitary tumor, is producing excess ACTH to drive the adrenal gland to make too much cortisol. In contrast, ACTH-independent forms of Cushing syndrome refer to those diseases where the ACTH levels are low, usually because of an adrenal tumor or other adrenal disorder. Today, we will be discussing Cushing's disease. Now, Cushing's disease is uncommon, has a prevalence of approximately 2.2 cases per 100,000 people internationally. So this is a rare disorder in general, and that's why it's often undiagnosed. Many clinicians don't see Cushing's disease during their career, and if they do, it may be with patients who do not have the full phenotype. If you look back at the pictures that you've seen probably over time of full-on Cushing's syndrome, with the changes including the changes in fat deposition, the moon face, the purple striae, it's hard often to diagnose because patients may not have all of these findings. And even if they do, oftentimes the patients go undiagnosed for years. And it may be 5, 10, or more years before a patient is diagnosed. Now, one of the consequences of this is the morbidity and mortality associated with Cushing syndrome. This is a multi-system disorder associated with many, many different comorbidities. For example, these patients frequently have hypertension, diabetes, hyperlipidemia, and therefore are at risk for cardiovascular disease. They also can have severe osteoporosis and may present with fractures of the hip or spine. These patients can be immunocompromised and maybe are at risk for infection just because of the presence of the high steroid levels. In addition, these patients often have depression. There may be psychiatric disorders associated with this, with mood disturbances, and so mood can be a problem with patients. In addition, mostly noted by the women who, by the way, are the preponderance of patients who have Cushing's disease, there may be hirsutism, acne, kind of androgen type of findings that are seen. And the mortality rates are higher in patients with Cushing syndrome, likely related to all of these comorbidities we just discussed, predominantly those of cardiovascular disease. So therefore, this is a disorder which has multi-system complications. I'm going to pass back to you, Tim, for the further conversation.
Thank you, Larry. Yeah, that's been my experience as well, is that patients that come in with Cushing's disease essentially have almost every organ system affected in some way. And as you've mentioned, most of the symptoms are not pathognomonic for Cushing specifically, so it leads to a lot of delays. We have with us a patient who has been living with Cushing, Sharmyn McGraw. And I just want to ask you, Sharmyn, to talk to us a little bit about your journey, all the way from diagnosis to sort of what you were going through with respect to facing the treatment and then management over the long term.
Thank you, Dr. Smith and Dr. Katznelson. It's so great to see you guys. And Larry, I so appreciate what you just said as a patient advocate for the last 23 years. And I have been lucky to be one of the lucky ones that I've been in remission since my first pituitary surgery in 2000. But things have not changed. Things have changed a lot, and I'm grateful for that. I feel we've moved the golf ball 1 inch closer to the sun. But as Larry was pointing out, there's a lot of pieces to this puzzle with Cushing's disease, and we're still seeing that even 23 years later. Of course, the high volume centers actually see a lot of Cushing's patients, and so we learned a lot. But from my perspective, dealing with hundreds of Cushing's patients through the 23 years I've been doing this, plus my own experience, in the beginning, I think part of the problem is there's so many pieces to this puzzle that the doctors are not recognizing it because maybe one doctor sees, like I went to a dermatologist for the acne on my face. I went to a cardiologist for my heart racing. I went to, a OBGYN thinking hormones. So as you can see, and that's not even counting the other doctors that I was seeing for maybe the joint pain and things like that. So putting the pieces together can be quite a challenge. As I finally got the diagnoses, some of the things that I dealt with from that level were that my ACTH was never over normal. So, normal was 60, mine was 58. My cortisol levels were in the 200s, which range was up to 108. But that was still a challenge for a couple of the doctors that I saw because they didn't quite understand ACTH with the cortisol levels. Another problem that I had was my tumor was so small, it wasn't seen on the MRI. And so about 30% of tumors, I think it is, are not seen on the MRI. But through my IPSS, and we confirmed that the source of the Cushing's was the pituitary. And for me, I think the first stages, and for most patients that I talk to, anxiety is the first noticeable problem, and not sleeping at night. And this becomes a real issue, but it's a common issue in society. So it's not alarming, to send up flags that, oh, you have Cushing's. But then the moon phase starts. And I think the moon phase is really the leading, even if the stomach isn't protruding or patients are not gaining weight, which happens. But definitely there are changes in the face that I see mostly. So I think those are two of the biggest things that I noticed. First is the anxiety, the sleeplessness, and the weight gain. But when we talk about the weight gain, a lot of people want to think it's just focused on the stomach, but like Larry was saying, this is not always the case. And, when we see thinning arms and legs, this is not always the case. And a lot of patients look pretty normal. There's, I never had this striad. I never had, and most patients don't. So the trickier part of the diagnoses, I feel, is actually giving the patient the benefit of the doubt when they come and say these things, and just do the testing to see if it could possibly be that. That's what I get most frustrated with, is the lack of the patient being understood or listened to.
Yeah, that's so important, which really brings us to the next thing we want to discuss, which is talking about treatment goals. And we can talk about them from the clinician's perspective. Larry, you could speak to this. When you talk to a patient, what do you discuss with them as the primary goals of treatment?
Right. Well, thank you. The primary goal from the medical standpoint is to normalize the cortisol. That is to determine the source of the problem, such as Cushing's disease, or pituitary tumor, and manage it to the point where the cortisol levels come down to normal. Along with that, in part because we are lowering the cortisol, will be to treat the associated comorbidities, the blood pressure rise, the diabetes, the weakness, the osteoporosis, improve the quality of life. So this would all be part of lowering cortisol. But I want to make the important point that some of these comorbidities, such as hypertension, diabetes, may not completely resolve with therapy. So it is important for the clinicians to continue to monitor for these comorbidities and treat them if they persist.
Sharmyn, when you were first being treated, talk to us about what your goals were for treatment.
Well, thank you. As Larry was mentioning, some of these things don't go away. And high blood pressure, although I'm very active and my diet is very good, it kind of have a history in my family of high blood pressure. So my blood pressure since Cushing's I'm still on medication for it. The anxiety has gotten better, and the sleeplessness has gotten better, but there are still things that are not better, which is primarily, I do not lose weight easily still. And my entire, obesity does not run in my family. Everybody in my family is very fit. So I am kind of the odd man out. So I do believe it is because of the Cushing's that I still, even though my levels are completely normalized, I have never since Cushing's been able to lose all of the weight. I think that's the biggest issue for me.
Yeah, that's a huge challenge. Well, thank you so much to Larry and to Sharmyn for joining us today for this discussion. Thank you so much for your insights, and we hope that you found these discussions useful.
Thank you.
Hello, my name is Dr. Larry Katznelson. I am a professor of neurosurgery and medicine and endocrinology at the Stanford University School of Medicine, and I'm also the medical director of the Pituitary Center at Stanford Healthcare. Today, I'm joined by my colleagues, first Dr. Tim Smith, who is a neurosurgeon scientist and surgical co-director of the Multidisciplinary Pituitary Center at the Brigham and Women's Hospital, the Neurosciences Center based in Boston, Massachusetts, and as well by Mrs. Sandy Ramsburg. Sandy is a pituitary nursing specialist and the nurse coordinator of the Pituitary Center at the Johns Hopkins Hospital, Division of Endocrinology, Diabetes and Metabolism in Baltimore, Maryland. And together today, we will be considering the clinical data for medical therapies along the patient's journey in treatment of Cushing's disease. Now, there are a number of studies that have looked at the pathways of therapy, and I'm referring specifically to one published in 2021 by the Pituitary Society that walks us through the algorithm of how we approach patients. And I'm going to ask first my colleague, Dr. Smith, to discuss the initial approach to these patients. Tim?
So when a patient is presenting with symptoms of potentially harboring Cushing's disease, they get worked up. And then once they're diagnosed, in general, for patients that are of appropriate age and without significant comorbidities that would prevent them from undergoing surgery, most patients undergo surgery as the first line of treatment. And the goal there is to identify a pituitary adenoma that is functional and to resect it completely. That is the goal of surgery. In general, however, when we're counseling patients, we discuss with them that this is going to be management of a chronic disease process. Surgery is not going to be necessarily for all patients the only treatment that they get. So we take them to surgery. Most patients will do well with the operation. There is recurrence rate, however. Anywhere from 5 to 35% of patients will reoccur. Half of those will reoccur within 5 years, most people within 10 years. And when that happens, many times we reconsider surgery as a second option, so another operation. And once we've exhausted this surgical option, that's when we start to consider whether or not the patient's going to need to go on for other forms of treatment, including medical therapy and radiotherapy. Medical therapy, I'll leave for you, Larry, to discuss. It's sort of in your wheelhouse. Some patients that have exhausted both surgical and medical treatment go on for radiosurgery, which is focused radiation to the region where they were harboring the adenoma. And in general, that is our approach.
Thanks, Tim. Tim, can you comment on the use and value of endoscopy in the surgical approach?
Oh, absolutely. I think endoscopy is one of the probably key technological innovations that has improved outcomes for patients over the years. When you think about, what we're trying to do as surgeons is we're trying to see what it is that we're resecting. In general, the pituitary gland is 1 to 1.5 centimeters in normal people. If we're trying to resect a tumor that's 3 to 5 millimeters, it's very, very small. Visualization is absolutely essential. In the 1950s, introduction of the microscope, which is where the magnification occurs outside the patient's body. There's a lens outside the patient that you're shining a light through the nostril, which was a step forward. And then in the 1990s, the endoscope was introduced, which is where cameras are mounted at the end of an instrument that's inserted through the nostril to the region that we're operating. And it just made incredible amount of difference for seeing what we're doing and maximizing the likelihood of resecting the tumor.
Thank you for that, Tim. In terms of use of medical therapies, I first want to make a comment on patients who have undergone radiotherapy. Radiosurgery can take several years or more to be effective. And while we are waiting for the efficacy of the radiosurgery or standard radiation approaches, patients need to be on medical therapy to control the hypercortisolism while waiting for the radiation to take effect. Now, when we think about medical therapy, we usually consider this as either mono or combination therapy, depending upon the extreme of the hypercortisolism. These patients require lifelong monitoring if they are on medical therapy, because these medical therapies do not destroy the underlying problem in terms of the tumor, but they control the cortisol. Bilateral adrenalectomy is usually utilized in those patients who have more advanced disease, who are not responding to medical therapy, or there may be specific situations, such as a woman who is interested in fertility, because none of the medical therapies to treat Cushing's disease are FDA approved for the management of Cushing's in a pregnant woman. So we often use bilateral adrenalectomy for those patients. We may also go right to bilateral adrenalectomy in patients who have ectopic Cushing's from a neuroendocrine malignancy. So if a patient has malignancy and will be requiring chemotherapy, we often use bilateral adrenalectomy upfront in order to ensure that we've controlled the hypercortisolism before these patients undergo chemotherapy. Now, when thinking about the medical therapy strategies, we think about medical therapies that target different levels of the hypothalamic pituitary adrenal axis. So there are medications that target directly the pituitary tumor, and I'll be discussing those in a second. We have medical therapies that target the adrenal gland to lower cortisol production. And we have a medical therapy that systemically blocks the glucocorticoid receptor, so it blocks wherever cortisol goes. So I'm going to start with the medical therapies that target the adrenal gland, because these are the ones that tend to be used most commonly. Internationally, ketoconazole and metirapone are the most commonly used. These are not FDA approved in the United States, but because they are inexpensive, they are used pretty much universally internationally. The only concern about ketoconazole is that it has a black box warning with liver function side effects, and there have been cases of significant liver damage in patients who receive ketoconazole. I have not seen that in my practice, and generally when we're using ketoconazole, we reduce if the dose, if not stop the ketoconazole, if patients have AST or ALT levels more than 2.5 times normal. There is a novel enantiomer of ketoconazole named levoketoconazole that recently came on the market and may also be effective similarly to ketoconazole. Oscilorhodostat is another new kid on the block in terms of blocking down the adrenal glands, highly effective, very well tolerated at normalizing cortisol levels. About 6 to 10% of women may have a rise in androgen levels associated with the block of the adrenal gland, and that may give rise to hirsutism and acne. So testosterone levels need to be monitored. For those patients who we wish to target the pituitary tumor itself, Paclitaxel is FDA approved and highly effective at not only normalizing cortisol in about a quarter of patients, but also in shrinking the tumor. A side effect needs to be monitored is hyperglycemia. Cabergoline, in off FDA label purposes, can also be used to treat the pituitary tumor. Again, we usually use these medications in those patients who have significant tumor burden that is not surgically accessible. The last class of medications is mifepristone, which is a glucocorticoid receptor blocker. So this blocks cortisol wherever it goes. We cannot monitor cortisol levels in these patients because cortisol levels do not fall. If anything, they may rise, but their impact is blocked by the receptor antagonist. Side effects to look out for with mifepristone include in women vaginal bleeding, and in both genders, hypertension and hypokalemia. Now, so there are benefits and limitations of each medical therapy. In patients who have large tumors, I described that at large pituitary tumors, we may move more quickly towards the paclitaxel or cabergoline that target the pituitary disorder. But really, these are all excellent medications, and I tried to separate earlier on using bilateral adrenalectomy for those patients who are not responding well to either mono or combination medical therapies or are interested in fertility. Now, I would like to pass the conversation to Sandy to comment from her experience as a nurse specialist on how patients approach medical therapies. Sandy?
Yes, hello. Thank you, Dr. Katznelson. One factor that causes resistance is the frequent lab testing that's involved. I've seen a few patients develop a severe needle phobia. Other factors include the cost, anxiety, and fear of what treatment entails. There are many side effects to the medications that treat Cushing disease. With paclitaxel, one of our patients actually presented to the ER several times with blood pressure spikes. With levoketoconazole, we had a patient develop elevated liver function tests. With cilostazol, patients have reported fatigue and headaches. And with mifepristone, peripheral edema and hypokalemia. Our patients are encouraged to proactively use their patient portal to report side effects directly to their physician. This method allows a quick response back to the patient. Further information can be obtained to triage the issue and make any adjustments to treatment or order any additional testing. A key challenge is ensuring that patients complete the necessary medical treatment and testing. Unfortunately, there is no perfect drug without side effects. Patients need support during therapy and encouragement to actively participate in their treatment.
Thank you, Sandy. And I want to thank both Dr. Smith and Ms. Ramsburg for their insights today. I am going to close this conversation today, and thank you all very much, and I hope you found this helpful. Hello there. My name is Larry Katznelson. I am a professor of neurosurgery and medicine in the Division of Endocrinology at Stanford University School of Medicine, and I am also the medical director of the Pituitary Center at Stanford Healthcare. I am delighted to be joined by my colleagues, first by Dr. Tim Smith, a neurosurgeon scientist and surgical co-director of the Multidisciplinary Pituitary Center at the Brigham and Women's Hospital, the Neurosciences Center in Boston, Massachusetts. I'm also joined by Mrs. Sandy Ramsburg. Sandy is a pituitary nursing specialist and the nurse coordinator of the Pituitary Center at the Johns Hopkins Hospital Division of Endocrinology, Diabetes, and Metabolism in Baltimore, Maryland. As well, I'm joined by Ms. Sharmyn McGraw, who is a patient who has had Cushing's disease. She lives in Orange County, California, and she has been in remission for 23 years and is a long-standing advocate, both nationally and internationally, for patients with pituitary diseases. In this section, we will be discussing individualized therapy and the role of the multidisciplinary team in the management of Cushing's disease. I want to start by having a conversation about how we approach the medical therapies The medical therapies are indicated mostly in patients who have persistent disease despite surgery. So therefore, the surgeons attempted to resect tumor, but there still is residual disease, and therefore cortisol levels are still high. We can consider radiation therapy at this point as well in the management of patients. But for the medical therapies, the goal here is to lower cortisol into the normal range. There is one class of medications, mifepristone, where the goal is to block cortisol. And in those patients, we cannot monitor cortisol, but also has the same long-term impact in terms of improving the comorbidities, the signs and symptoms of Cushing syndrome. Now, whenever we start a medical therapy, we need to monitor the endpoints, which are usually cortisol levels for most of these patients. In those patients where we utilize a medication and the patient has persistent activity, meaning that the cortisol levels are still high, then sometimes we use combination therapy, where we will add two medications together or even more, depending upon the rapidity with which we need to normalize the cortisol or just specific to that patient's management. But it's not uncommon that we have more than one medication as combination therapy for these patients, and we're looking not only for the cortisol levels, but evidence of clinical improvement. Now, when we are thinking about the medical therapy, it's critical to think about what this means for the patients. And in having that conversation, I'm asking Sandy to comment further on her experience of working with patients and how patients think about their approaches to medical therapies. Sandy?
Thank you, Dr. Katznelson. A lot of patients approach medical therapy with apprehension. The role of the nurse caring for patients with Cushing disease begins with assessing the knowledge and expectations of treatment outcomes. It includes providing individualized education according to the medication prescribed, what side effects to expect and what needs to report it to their physician. There's a need to reinforce the importance of lab testing and adhering to the return visit schedule. It's also important to encourage patients to actively participate in their treatment and provide reassurance and support as needed. Addressing knowledge deficits and expectations increase the likelihood of compliance. And the goal of drug therapy is that it will increase the quality of life.
Thank you, Sandy. I would also like to pass the conversation to Tim to discuss, in his view, as a surgeon, how many of the specialists interact in managing these patients along their treatment journey. Tim?
That is such an important issue. I think for patients with Cushing's disease, from the initial shock of the diagnosis and the struggles they've already had with the symptoms, they're typically introduced either to an endocrinologist first or to the neurosurgeon first, once this pituitary tumor has been discovered and it's been diagnosed. And I think such an important expectation to set early on that the treatment of this is going to be lifelong, chronic, it's management. And that management team needs to be built. And in general, that team is going to consist of a number of specialists. In addition to the neuroendocrinologist and the neurosurgeon, there's also going to be team members added to this based upon where the patient is in life, what their expectations and goals are. If they're a young woman, for instance, then we'll involve an OBGYN. If they have skin issues, then we'll involve a dermatologist. If they have issues related to heart disease, then a cardiologist. So depending on what the signs and symptoms are, it's very important to impress upon the patient early on that we're going to be building the perfect team around them. And what's interesting is, if you look at the World Health Organization or the World Association for Pituitary Organizations in 2019, there was a global survey from both a provider and a patient perspective. And what's very, very clear is that many, many people view the endocrinologist as the quarterback of this team. But not all providers and all patients are aware of the breadth of disciplines that could be involved in their care. And I think that's a very important thing to emphasize.
Thank you, Tim. I agree with that. The collaborations between the specialists and the nurse specialists are critical. really, in managing these patients. Now that we've discussed some basic approaches from the healthcare provider side, I think it's important to think about what's the unmet need from the patient standpoint. And to address such unmet needs from someone who herself has had Cushing's disease, I'm going to ask Sharmyn to speak about her experience. Sharmyn?
Thank you, Dr. Katznelson. And there is some unmet needs with patients. And I think, like Dr. Smith was saying, that there are other people involved with our treatment, but I think one of the things that is huge, and I know literally hundreds of Cushing's patients, and the mental health part of this journey is been underestimated. And I think we're now seeing where body-mind health is much more important than we did in the past. But for me and all the patients that I help support, therapy, whether it be through a counselor or through a psychiatrist, or usually it's a therapist of some sort, or even through your church, if that's what you have. But the most important part that I see is this is a team effort. It's too big for one person. It's too big for a family member. It's way beyond the scope of that. And I have a lot of patients, maybe their doctor will recommend they see a therapist, and they come to me and they go, my doctor thinks I'm crazy. And I say, well, I know you're not crazy, but I'm going to tell you, I agree with them. Therapy is important from the perspective that a therapist can help you sort things out. It's not your family job. It's above their pay grade. As well as a lot of patients will come to me and say, but a therapist doesn't know anything about hormones. A therapist doesn't have to know about their hormones or the disease. A therapist, if they are well trained, does know about trauma, the years that it took you to get diagnosed, the years that the patient was misunderstood, the problems that it's caused in their family, the unbaked cake is what I call it, the problems they came to with this disease, long before the disease. And what I've noticed is after the diagnoses, we have to manage their expectations, whether it be with a surgery, even that was successful. Recovery takes a while, 18 months. Sometimes they don't feel better, but eventually they feel better. With the medication, a lot of times they think it's a magic pill and I should take the pill and feel better. That's not, we have to manage those expectations. Oftentimes the therapist can help us manage expectations of family members and the things that came on top of the disease. And because I'm seeing a lot of patients cluster everything into the disease, and then they eventually become identified with the disease. So I think the most important thing is to remember that we are not our disease, but what tools do we need besides our medical team to help us make sure that we're living a full life and the best quality of life? And that takes team effort, and mental health is a big part of that.
Sharmyn, that was so powerful. Thank you for your comments there. I am at this point going to close this discussion, and I want to thank my colleagues, Dr. Smith, Mrs. Ramsburg, and Sharmyn for their contributions. We hope you have found these discussions useful. Thank you.
Thank you.